welcome to my channel. And I just want to describe about the NICE guidelines, which is being frequently been asked, and it has been troubled in many situations of the clinical conditions. And it is of course been very much demanding in the medical practitioners regarding the management of common uh, metabolic conditions, as well as some infectious diseases also. And of course, coming on the hypertension, and this guideline is very much important uh, in the case of these kind of lifestyle disorders. So just going on with the latest updation that was being done in the November 2023. So I will explain all those things which has been updated, along with which its original guidelines, content of this there. You can see the overview and its recommendations. All has been shortened to the 5 subtopics, and there are also very much things. So I will complete it rather in the two parts. First part we have the recommendations, and let's on the other parts we'll go for the recommendation for the research and its impact and rationale. So the overview just being provided here, that is for the healthcare professionals and the providers and governors of the health departments. So this is guideline that is primarily for the hypertension in adults aged 18 and above, including people with the type 2 diabetes, and other also the conditions like CKD and other disorders. So type 1 diabetes, so that has been directed under the separate guidelines of that respective diseases. So the recommendation is here that recommendation has been provided for the type 2 diabetes, and it is now again said here, and also which I was saying that CKD and type 1 diabetes and hypertension in pregnancy, all the points has been covered, but for going on these diseases, so you have to go on this link so that you can find their guidelines. So you have to just get on with these guidelines that has been provided here for these diseases. So that will not be covered under this hypertension guidelines. And some of the problem and objective are to diagnose the hypertension. So this is very much important, and now for that you have to just measure the blood pressures, and accurately you have to take it out according to the guideline. That there should be a proper training for the healthcare professionals, and also there may be some of the faults in the automated devices, so you have to take it by manual measuring, and after that you have to calculate all those things, because in the case of automatic machines there are lots of error in the case of atrial fibrillations and irregular rhythms, uh, like pulse irregularity. So these kinds of things that is to be very much cared of. In the case of postural hypertension, and of course one of the things that that is very much important, that while measuring the blood pressure in the clinic or on, just we have to set standardizations, and the temperature setting should be very good so that the patients should not be having any exertions, and we patients should be relaxed and quiet and seated, and their arms be outstretched and supported. So if all those things will be there, so the it is makes some chance that the blood pressure monitoring will be very much accurate. And after coming to the postural hypertension, that the patients with the symptom of postural hypertension, including fall or postural dizziness. So you have to just measure the blood pressure with the patient lying on the back, and you can consider also the seated position if it is inconvenient to for the person lying down, but is not being recommended. Measure the blood pressure again after the person has been standing at least 1 minute. So you have to just take it online, supine, and after that you have to make the patient stand, and after that you have to take it again. And if the person's systolic blood pressure falls by 20 millimeter of mercury or more, their diastolic blood pressure or their diastolic BP falls by 10 millimeter of mercury or more uh, after the standing at least 1 minute. So you have to just consider likely causes, including reviewing their current medications and manage appropriately. And just for example, you just go to the separate guidelines for the older people and measure the subsequent blood pressure with the standing and consider referral to specialist care if the postural hypertension persists. And if the pressure is dropped less than the threshold in recommendation, uh, in the previous recommendation I have said, despite suggested symptom, repeat the measurement, this time starting with the person lying on their back, and consider referring the person for the specialist assessment if it is if the pressure measurement do not confirm the postural hypertension despite suggestive symptom. So if there is any kind of dissimilarity with your finding upon these procedures, you have to just go for referral of that patient. Diagnosing the hypertension, when the considering a diagnosis, measure the blood pressure in both arms, and if the difference in the reading between the arm is more than 15 millimeter of mercury, then repeat the measurement. If the difference in the reading between the arms remain more than 15 millimeter of mercury on the second measurement, measure the subsequent blood pressure in the arm with the higher reading. So if suppose that you measure the blood pressure on one on the right, you just find the 155 millimeter of mercury, the systolic blood pressure, and 155 upon 90, and on the other hand you just on the left hand you just find the 140 upon 90 millimeter of mercury. So you just have to calculate it, you just have to measure it again, and if you find that this this reading comes again, then you just have to take to the reading of right hand, that is which is higher. So 155 should be the clinical reading. And if the blood pressure measured in the clinic is 140 by 90 millimeter of mercury or higher, so you have to just take a second measurement during the consultation, and if the measurement is substantially different from the first, take the third measurement. So this is the thing, that you are not be very much stick to the one time reading. So you have to just again take it, and after that if it comes different, then you have to take a third measurement. So you have to record the lower of the last two measurement as the clinic blood pressure. You just find, you just suppose that you measure the blood pressure which comes earlier in the 145 by 9 145 by 100, and again you just measure it, then it comes the 155 by 90. So after that you just find the difference over here, and you have to take it again, and you just can find the reading of 150 by 100. So you have to just calculate the last two readings, which is 145 and 150, and the lower of the last two measurement as the clinic blood pressure. So the last two measurement which comes here is that 155 and 150. So you have to take it 150 by 90. If the clinic blood pressure is between 140 by 90 millimeter of mercury and 180 by 120 millimeter of mercury, offer ambulatory blood pressure monitoring. So ABPM is to be preferred for confirmatory diagnosis. And see the section on define who to refer for people with clinical blood pressure 180 by 120 millimeter of mercury or higher. So after that you will see there that how to whom you have to prefer for blood pressure above 120 by 80 120. If ABPM is unsuitable on the person is being unable to tolerate, because I mean it's very much not suitable for the older patients, so you just have to take it all along the day. So you just have to offer home blood pressure monitoring, because you just have the if you have the office time and other times, so you have the lots of things that you have to take it out. So if that the patient is not able to tolerate it, and you have to just prefer for the home blood pressure monitoring, but recommended APPM is recommended. So is to confirm the diagnosis of hypertension. While waiting for the confirmation of a diagnosis of hypertension, carry out the investigation for target organ damage. So when while you are just getting all those things, ABPM or home blood pressure reading, so in between of that you have to just get investigated for target organ damage. For the followed by the formal assessment of cardiovascular risk using assessment tools. And what a kind of target organ damage. So you have to just check it for the renal functions, how there is working, like estimated GFR and albumin creatinine ratio ACR and hematuria, and of course the functioning of liver, and of course you have to take it out the fundus checking, that any kind of papilledema or any kind of injury to the retina is there happening, and other kinds of things like hyperlipidemia or dyslipidemia, these kinds of things you have to check it out. I will just set it in the further section. So when the using the ABPM to confirm a diagnosis of hypertension, ensure that at least two measurements per hour taken during the person's usual waking hours. So just to take the reading between the 8 a.m. to the 10 p.m. and 1 hour just have the two readings, and use the average value of at least 14 measurements taken during the person's visual waking hours to confirm the diagnosis of the hypertension. So there should be at least 14, not less than that. And while using the home blood pressure to confirm diagnosis, ensure that for each blood pressure recording, two consecutive measurements are taken, at least 1 minute apart, and with the person seated. And blood pressure is recorded twice daily, ideally in the morning and evening. And the blood pressure recording continues for at least 4 days, but ideally for 7 days. So there should be, you have to tell the patient to make a diary, and it is just calculate all those reading and just read it down, just write it down. And it is very much important that discard the measurement taken on the first day and use the average value of all the remaining measurement to confirm a diagnosis of hypertension. So this is very much important, that the first day the patient is anxious, and the critically the BP is usually higher regarding to concern of the diagnosis. So you have to just discard the value of the first day. After that, confirm diagnosis of hypertension in people with so there is the measurement now just taken out, but how you just take the diagnosis as a confirmatory diagnosis. So it has been given here, very very much important, that a clinical blood pressure of 140 upon 90 millimeter of mercury or higher. So the clinic blood pressure should be 140 upon 90 after all the procedure which I have said here. And ABPM daytime average or SBPM average of 135 by 85 millimeter of mercury or higher. So these two things is very important. Only the clinical blood pressure of 140 upon 90 does not provide a confirmatory diagnosis. This is not okay. And after that you have to just get out for the ABPM or HBPM recommended. ABPM is recommended, and which should be above 135 by 85 or higher. If hypertension is not diagnosed but there is evidence of target organ damage, consider carrying out the investigation for alternative cause of target organ damage. If there is no evidence and it is not diagnosed, then you have to just get for the target organ damage. If the hypertension is not diagnosed, measure the person's clinic blood pressure at least every 5 years subsequently. So you just make a routine checkup for the measurement of for the diagnosis of the hypertension every 5 years, and consider measuring more frequently if the person's clinic blood pressure is close to 140 by 90 mm of mercury. So if it is close to that, like the 136 or 138, 136 by 80 and 138 by 85, so this kind of thing, and you have to just make it when the patients come for your clinic, like 6 monthly or yearly, you have to just uh, check it out. Another blood pressure measurement for patients with type 2 diabetes, and to just very very much cautious, because in type 2 diabetes, here that you measure the blood pressure at least annually in the adult with the type 2 diabetes without previously diagnosed hypertension or renal diseases, and offer and reinforce preventive lifestyle advices. So yes, very very much cautious when you deal with the type 2 diabetes patients, and you must take it yearly measurement of blood pressure in these patients uh, without any fact that he have been diagnosed hypertension or renal disease earlier. And here it is very very much important that you must reinforce the lifestyle advice. So exercising and proper limitation of salt and proper daily lifestyle, like sleeping on the time and just getting on the bed, getting from the bed in the morning time, that is very very much important. And specialist investigation for possible secondary causes of the hypertension. So consider the need for a specialist investigation in the science, where you just to find the secondary cause. You just have the potential clues regarding secondary causes of hypertension in the, like the patients below the age of 40 years, and he's getting the hypertension symptoms, and also the reading of 140 by 9 140 by 90 or higher. So yes, to just go for the specialist investigations, as you must find these clues like the pheocytochroma and other disorder like the hyperthyroidism. So like that, you have to refer for the nephrologist or endocrinologist, what may be the case. The most important is the assessing the cardiovascular risk and target organ damage, which was just going to there, like for the guidance of early identifications. You just have to go to the for the CKD. You have to just go for the separate guidelines. So here they use a formal estimation of CV risk to discuss prognosis and healthcare options with the patients, both for the raised blood pressure and other modifiable risk factors. You have to just discuss all those things related with the estimation and prognosis after calculating the risk. Estimate the CV risk in the line with the recommendation of NICE guideline, and use the clinical blood pressure measurement to calculate cardiovascular risk. And so there is a separate guidelines on the cardiovascular risk. We have to just calculate the Q risk score. So after it comes the score of the about 10%, then you have to just go through the guidelines of the potential cardiovascular risk and cardiovascular diseases. So in that you have to just go for the statins and others, cholesterol lowering drugs, and all those. Of course, the daily lifestyles and other kind of advices mm, you have to just provide to the patients. So it is very much important to estimate the cardiovascular risk in the patients with the hypertension. And one thing that is very important, that you use the clinic blood pressure measurement to calculate the cardiovascular risk. In order to be use the ABPM or SBPM readings for calculating the Q risk. So there is also the other guidelines on the cardiovasculars, which I will make the prescribe in the subsequent days, and of course I will let you make the assessment of the Q risk. This has been just you can calculate here. Just check these risks in the Q risk 3 lifetime. You just go for the website qrisk.org and just calculate the risk with the information regarding here, that mentioning the age and other informations, clinical informations like diabetes status and other diseases like CKD or rheumatoid arthritis, SLE, and all those readings previously taken, systolic or diastolic, and smoking status, cholesterol, HDL ratio, height and weight. So this you have to take the readings and you just get the Q risk score. So just go here to they all those things. And for the people with hypertension, offer to test for the presence of protein in the urine by sending a urine sample for estimation of albumin creatinine ratio, and test for the hematuria using a region strip. So you just have to take the target organ damage study, just like that any kind of a as chronic kidney disease there is not. So you have to just take out the protein calculation and also the CR, and take a blood sample to measure the glycated hemoglobin, HbA1c, electrolyte, creatinine, and EGFR, and total cholesterol and HDL cholesterol. You have to take the like to measure the kind of diabetes and other cardiovascular or renal risk. Examine the fundi for the presence of hypertensive retinopathy, and if the blood pressure is above the F180 by 120 years to must check out the fundus for papilledema in the case of malignant accelerated hypertension. Will be in the subsequent guidelines, I think. For that, so this was the actually the target organ investigation. We have to just do it when you are diagnosing these situations, diagnosing this disease. So it take a time of 7 days, and so 4 to 7 days. So during this time, you have to do these investigations. While treating and monitoring the hypertension is very, very much important, which I was telling you now. So, lifestyle intervention is very much given priority for the guidance on the prevention of obesity and cardiovascular disease. So, the separate guidelines there. So, there are lots of things in that guidelines has been provided. I will provide that guidelines also. So, after offer a lifestyle advice to people with suspected or diagnosed hypertension, continue to offer it periodically. You have to once you given the lifestyle advice like quitting the smoking and cessation of alcohol intake and proper exercise, and of course the other kind of lifestyle activities which you have been provide you have just given like diet and other things, so you have to take it out with the continuation. Ask about the people's diet and exercise patterns because healthy diet and regular exercise can reduce blood pressure, which I told now. Offer appropriate guidance and written or audiovisual material to promote lifestyle changes. You have to just make it on some documentations so that patient comply on that things, and you just remember all those things. Ask about the people's alcohol consumptions and encourage a reduced intake if you drink excessively, because this can reduce the blood pressure and has broader health benefits. And the recommendation on alcohol use disorders has also been provided separately in the 2004 guideline, and that has been amended in 2019 guideline also. Discourage excessive consumption of coffee and other coffee rich product, like this India and South Asian countries. There are lots of customs related to the tea and other things, like when we meet and the friends meet in the so they just offer the tea or coffee when just they embrace to each other. So these kinds of things, and the patients with the hypertension should explain these things that I am not able to take it, or my doctor has prescribed to limit the consumption of caffeine products. Encourage people to keep their dietary sodium intake low. That is very, very much important and very much significant, either by reducing or substituting sodium salt, as this can reduce the blood pressure. So in the Indian country, Indian subcontinent, they just have the rock salt also. So that is very, very much beneficial in maintaining the blood pressure because it has the low sodium. Or you just have in other countries, you just may take the low sodium salt, another salt which has low sodium content. Note that the salt substitute contain the potassium chloride, should not be used by older people and people with diabetes, pregnant women, and with the CKD, and some taking some antihypertensive drugs such as ACE inhibitor and angiotensin and ARB, because these drugs just increases the potassium level and may cause sometime the hyperkalemia. It is not very much often, but yes, there is a risk in taking the high quantity of potassium in these patients who take the ACE inhibitors or ARB. Do not offer calcium, magnesium, or potassium supplement as a method for reducing blood pressure. So that is very, very much important. If the patient take the calcium and other solutes, other kind of supplements, like these can worsen the problem of kidney diseases also. It can attenuate the effect of antihypertensive drugs. Offer advice and help to smokers to stop smoking. That is very much important in the case of smokers. Inform people about the local initiative, for example, healthcare teams or patient organizations that support and promote the lifestyle changes. Uh, Starting the antihypertensive drug treatment, that is very much crucial here, which I was telling about the core of this guideline. NICE has produced a patient decision aid on treatment options for hypertension to help people and their healthcare professional discuss the different type of treatment and make a decision that is right for each person. So this kind of thing that people and healthcare professionals must discuss to each other with the kind of treatment that is being required and that they want to go ahead with that. So for advice on shared decision making for the for the medicine, you can see the information on patient decision ads also. Because the many times the patient do not want to get these medicines, so there is a lot of confusions regarding the patient's mind. So just to there are separate guidelines to get on these the guidelines on optimization. And here just have offered the antihypertensive drug treatment in addition to lifestyle advice to adults of any age with persistent stage 2 hypertension. So what is the stage 2 hypertension? That is above 160 by 100, and you can see here the stage 2 hypertension, like the stage 1, which is ranging from 140 by 90 millimeter of mercury to 159 by 99 millimeter of mercury, and subsequent this is the clinical blood pressure, and subsequent ABPM, daytime average, or SBPM average should be ranging from 135 by 85 to 149 by 94. And in the stage 2 hypertension, the clinical blood pressure of 160 by 100 mm of mercury or higher, but less than 180 by 120 millimeter mercury, and subsequent ABPM average, HBPM and HBPM average should be having of 150 by 95 millimeter of mercury or higher. In stage 3 or severe hypertension, that is being classified as 180 by 120 millimeter of mercury clinical clinical reading. So moving ahead with that, so offer antihypertensive drug treatment with the persons having persistent stage 2 hypertension, means having the clinic blood pressure of 160 by 100, above in the case of any age of the patient, must having the adult of any age. So you have to provide the antihypertensive treatment. And of course, we just discussed the starting antihypertensive drug treatment in addition to lifestyle advice with adults aged under 80 with persistent stage 1 hypertension or who have one or more of the following. So you have to provide the antihypertensive treatment in the case of old age patients having the age more than 80 with stage 1 hypertension, means around 140 above 140 millimeter of mercury to 159 by 99 millimeter of mercury. So in that case you have to provide the antihypertensive, and or who have one or more of the following diseases, symptoms, or conditions like target organ damage, and like the potential risk of uh, chronic diseases, and potential risk of strokes, and um, having hypertensive retinopathy, uh, the cardiovascular diseases, renal disease, diabetes, and estimated 10-year risk of cardiovascular disease of 10% or more. So you can calculate on the Q risk score format. And of course, going on that, so one of the things that this is the 1410 is for the guideline is for the age under 80. So I have just said, I think, above 80, so that should be corrected here, that above the 80 there is a separate guideline that you have to go for in the subsequent section here. And after that, considering antihypertensive drug treatment, uh, in addition to lifestyle advice, the patient under 60 with the stage 1 hypertension, that is 140 to 159 systolic blood pressure, uh, and an estimated 10-year risk below 10%. Bear in mind that the 10-year risk may underestimate the lifetime probability of developing cardiovascular diseases. So just you have to consider the Q score for cardiovascular risk, and it comes the less than 10% with the patient is under 60 with the stage 1 hypertension. So then you have to start the antihypertensive drug treatment, and consider the drug treatment in addition to lifestyle advice for patient over 80 with stage 1 hypertension if the clinical pressure is over 150 by 90 millimeter of mercury. So that is very much important. If you are just below the 80, then you can start the drug treatment over the 140 by 90 millimeter of mercury, while in the case of aged over 80, you can say here with a stage 1 hypertension, then you just go for the treatment over 150 by 90 millimeter of mercury. Before that, you have seen there uh, that is under 80, and consider and of course after these things, for the adults age under 40, consider seeking a specialist evaluation of secondary causes of hypertension. And after that, the blood pressure target, that is very much important. The classification here, the patient under 80 with hypertension, type 1 diabetes, plus ACR less than 70 mg per millimole, or chronic kidney disease plus ACR less than 70 mg per millimole. So you have to set the target below 140 by 90. If any condition here along with the hypertension for the patient under the 80, and if there is type 1 diabetes plus ACR ratio of 70 mg per millimole or more, or CKD plus ACR of 70 mg per millimole or more, so then you have to set the target of 130 by 80 millimeter of mercury. So that is very much important here. And the table 2, that is for the clinical blood pressure target for people is 80 or over. So for the patient with 80 or above, the hypertension with or without type 2 diabetes, or there is a type 1 diabetes regardless of ACR. You have to keep it below 150 by 90, and if there is CKD plus ACR less than 170 70 mg per millimole, then you have to set it below 140 by 90 millimeter of mercury. And so here they repeat it with the hypertension, that is regardless of type 2 diabetes and type 1 diabetes, that to make it below 150 by 90, and CKD with ACR less than 70 millimeter 70 mg per millimole, that you should keep it below 140 by 90. The target should be there. In the case of CKD plus ACR of 70 mg per millimole or more, then you have to set it below 130 by 80 millimeter of mercury. So most suitable one thing is that you have to, in the general practice, the patients of hypertension, when it comes with or without the type 2 diabetes, you have to make it below 150 by 90 in the case of aged 80 or ever, or and in the case of under 80 you have to make it below 140 by 90. And in case of their the target organ damage, you can see here the 130 by 80 in the in under 80 age, and above 80 age, then you have to keep it below 140 by 90. Use the clinical blood pressure measurement to monitor the response with the hypertension. So it means that you have to make it frequently monitor in the patient with the hypertension, and you must check it for the clinical blood pressure in spite of ABPM or SBPM, or the home monitoring should not be recommended. And check for the postural hypertension in people with hypertension and type 2 diabetes, and symptoms of hypertension, postural hypertension, and people's age 80 and above. And in the people with the potential drop, just have to treat to blood pressure target based on standing blood pressure in spite of lying supine. Advise the people with the hypertension choose to self-monitor their blood pressure to use SBPM, and consider the ABPM or SBPM in addition to clinical blood pressure measurement for people with hypertension identified as a white coat effect or masked hypertension, in which the clinical and non-clinical blood pressure results are conflicting. So you have to just advise for the ABPM or SBPM in addition to the clinical blood pressure, and be aware that the corresponding measurement for ABPM or SBPM are 5 millimeter of mercury lower than the for the clinical measurement. So here you can say that the ABPM or SBPM should not be lower than the 5 millimeter of mercury. And the things is very important that ABPM or SBPM, that when it is taken, so the reduced blood pressure should be maintained below 135.95 for under 80 age, and below 145.85 for the age above 80. In the case of clinical blood pressure, you know that it has been provided earlier that aged under 80, So you should maintain it below 140 by 19, and in the case of above 80 age, then you have to just make it below 150 by 19. Use the same blood pressure target with or without the cardiovascular uh, disease. So there should be no difference in that. But if there is any kind of cardiovascular risk, then you have to go with that guideline relating to the cardiovascular risk according to the Q score. Treatment when type 2 diabetes is diagnosed for an adult with type 2 diabetes on hypertensive drug treatment when diabetes is diagnosed, review blood pressure control and medication used. Make change only if there is a poor control or if current treatment is not appropriate because of microvascular complication or metabolic problem. And after that, you can see here a step 1 treatment is being provided here. Offer an ACE inhibitor or ARB to adult starting step 1 hypertensive treatment who have type 2 diabetes and are of any age or family origin, uh, except the black African or African Caribbean. So there is a separate recommendation for them, and who are age gender at 55 but not of black African or African Caribbean family origin because having low renin level, and this is very much important. If an AC inhibitor is not tolerated, for example, because of cough, offer an ARB to treat hypertension. So this is very much important because lots of patients come with the side effect, adverse effect of the AC inhibitor, that persistent dry coughing. In case the ARB is being provided, and in Indian subcontinent, ARB is very much common. Like the telmisartan is very much uh, common drug of treatment in the case of hypertension. Do not So there is also the thing that ACM and ARB should not be used together, and it is not for also use in pregnancy and breastfeeding condition. Do not combine an AC inhibitor with the ARB. So here is it. Offer calcium channel blocker to the adult starting step 1 hypertension treatment who are age 35 or above and do not have type 2 diabetes and are of black African race, don't have type 2 diabetes. Because of the type 2 diabetes, in that case you may need to start the beta blockers in the case of CCB because their tachycardia condition happens. So in that case, if there is condition of hypoglycemia, in the case of oral hypoglycemic, taking oral hypoglycemic drugs or agent in the type 2 diabetes, so then that symptom will be masked. The symptom of hypoglycemia will be masked in the case of taking beta blocker. So it is therefore not recommended to initiate the CCB in the case of type 2 diabetes mellitus. And if CCB is not tolerated because of edema, so the pedal edema is very much common in that patient, offer a thiazide like diuretic. So you can say that the indapamide has been very much common in the case of CCB is not tolerated, so it is being added to treat hypertension. And if there is evidence of high heart failure, offer a thiazide like diabetic and follow the NICE guideline on chronic heart failure. That thiazide like diuretics are mm, very very efficacious in that case. It's the moderate ceiling diuretic, and you just can use it without any adverse, very significant adverse effect. But in the case, I have to just measure on those potassium levels and check out it with the case of hyperkalemia, that is that may be developed while using these thiazide like diuretics. So you may provide some of the potassium supplements there. You may provide, but that is not very much recommended. Other than the case of the hypokalemia. And if you're starting or changing diuretic treatment, offer thiazide-like diuretics such as indapamide in preference of conventional thiazide diuretic like bendroflumethiazide or chlorothiazide, hydrochlorothiazide, because it has the potential antihypertensive effect of indapamide, so it is being preferred here. And also having very low or you can say the no adverse effect of causing uh, GFR lowering of GFR or CKD, because most of diuretics are not being suitable for the chronic kidney disease, especially the thiazide-like drugs or high or loop diuretics. But indapamide is quite safe in the case of GFR or having CKD. For the adults with the hypertension already having treatment with pendroflumethiazide or hydrochlorothiazide who have been stable continue their treatment. So it is not necessary to change these things unless until there are not any significant adverse effect or not impliance of the guideline. And step 2 treatment is for considering the next step treatment for hypertension. Discuss the patient if they are taking medicine as prescribed or supported. So when the patients come again and say that it is not the and is reading or the things, that is blood pressure is not in compliance with the target, then you must ask about the patient that how he is just monitoring it and what step he is taking or what kind of adherence he has been shown on the prescription or advice. If hypertension is not controlled in the adults, taking step 1 treatment of ACE inhibitor or ARB, offer the choice of one of the following drug in addition to step 1 treatment like a CCB or a thiazide like diuretic. So you may add here these things like addition to that ARB or CCB or thiazide like diuretic. If hypertension is not controlled in adults taking step 1 treatment of a CCB, then you may add following things like NIC inhibitor or ARB or thiazide like diuretic as the condition may be. So you have to just here mention should just get on these things that here the patient is having the diabetes mellitus. So you have to just avoid the CCB as much as possible. And if the case of their hyperkalemia is being developed in the patient due to the use of AC inhibitor or ARB, then you just have to take thiazide like diuretics. So these things they are to just focus on. And if the hypertension is not controlled in the adult of vehicle frequency, uh, you have to just not getting compliance with the step 1 treatment, consider an ARB in preference to AC inhibitor because that works well in them in addition to the step 1 treatment. So first of all, that you not start ARB or AC in that black Africans, but If there is any things like that, then you may go for ARB. Step 3 treatment, just before, if the patient doesn't get maintained of that blood pressure target, even after addition of drugs, then you must go for the step 3 treatment. Um, you must review the patient's medication to ensure that they are adhering with these medicines or not. If the hypertension is not controlled after taking treatment, then you may have the combinations of an ACB inhibitor or ARB and ACB and CCB, sorry, and thiazide like diuretic such as indapamide and hydrochlorothiazide. And after that, if the patient doesn't get compliant with this thing, and the step 3 could not get maintained with that target, uh, then so in that case, it's been regarded as a patient having resistant hypertension is not able to get controlled after the step 3 treatment. So you have to just consider further diuretic therapy with a low dose spironolactone for adults with potassium sparing diuretics with resistant hypertension starting, who have the blood potassium level of 4.5 millimole per liter or less. Use particular caution in patients with a reduced EGFR because they have an increased risk of hyperkalemia. So you have to just take it on caution when using further diuretic therapy for step 4 treatment of resistant hypertension. And it just monitor frequently the blood sodium and potassium and renal function within 1 month of starting treatment and repeat as needed out thereafter. And consider an alpha blocker or beta blocker for adults with resistant hypertension starting step 4 treatment who have a blood potassium level of more than 4.5 millimole per liter. If the blood pressure remains uncontrolled in the patients having resistant hypertension, taking the optimal tolerated dose of 4 drugs, seek a specialist advice, go for the specialist. So these kinds of things I have covered, and finally in the case of identifying to refer for the same day specialist review. So the patient having a stage 3 hypertension, that is clinical blood pressure of more than 180 by 120, um, but no symptom or signs, so they indicate having the clinical blood pressure of about 180 by 120, so they need a same day referral. Having no symptoms or signs, uh, carry out an investigation for target organ damage as soon as possible. So if the target organ damage is identified, consider starting antihypertensive drug treatment immediately without waiting for the result of ABPM or SBPM. And if no target organ damage is identified, confirm diagnosis by repeating clinical blood pressure measurement within the 7 days, or consider the monitoring using ABPM or SBPM if ABPM is not suitable for tolerated as recommended earlier, and ensuring a clinical review within the 7 days. Refer people for a specialist assessment carried out on the same day if they have a clinic blood pressure of 180 by 90 of mercury and higher with the sign of retinal hemorrhage or papilledema and life-threatening symptom such as knee onset confusion, chest pain, life-threatening symptoms such as chest pain or new onset confusion and signs of heart failure and acute kidney injury. So repair people for specialist assessment on the same day if pheocytochroma, headache palpitation, pallor, abdominal pain or diaphoresis. So these kinds of things you have to just refer out immediately for the same day specialist review. So these are all from the NAS guideline, as I have said earlier. So the other things are being just things I will discuss in the subsequent ways if it will be possible. So make it out to spread this guideline and the between the clinical practitioner and the general practitioner, and like and subscribe for the further notifications. Thank you very much all.